All right, why don't we go ahead and start? Good morning and welcome to Medical Grand Rounds. Today is our Hematology Oncology Case Conference, and I'm pleased to introduce Dr. Amy Bodrog, who joined our group last fall after she completed her Hematology Oncology Fellowship at the University of Rochester. Dr. Bodrog has been practicing at our Linden Oak site as well as at our Greece Unity site. And you'll also see her on call on service at both of those sites, actually. So without further ado, Dr. Bodrog is going to tell us about colon cancer based on a case. Dr. Bodrog.
All right, thank you. And thank you for the introduction. So today I'll talk about colon cancer. For the sake of the case and for the time of the conference, we're not going to go into rectal cancer as much, but essentially in metastatic disease, these are treated the same. So we'll start with the case. So we had a 60-year-old man in May of last year. He presented to his rheumatologist. He had a long-standing history of rheumatoid arthritis on Humira and followed regularly, but he was found to have a new microcytic anemia. Hemoglobin had been 8. He had been feeling progressively fatigued. He hadn't lost any weight. He hadn't seen any blood in his stool, but his hemoglobin had gone from 14.3 at his baseline down to the new level of 8. He was iron deficient. We can see the iron saturation of 4 and the high TIBC. Just a little bit more history about this gentleman. Besides rheumatoid arthritis, he also had a history of an essential tremor. He'd had no past surgeries. His family history was significant for gastric cancer in a paternal uncle and possibly his paternal grandfather. He's married, works as an engineer, working towards retirement, former smoker years ago, rare alcohol use, no drugs. So the rheumatologist contacts his primary care, who then follows through with an endoscopy and colonoscopy. For individuals greater than 50 with new iron deficiency, the concern would be something causing a gastrointestinal bleed. Unfortunately, on colonoscopy, there is a 5-centimeter ulcerated and friable mass circumferential at the ileocecal valve that's been found. This is biopsied at the time of the colonoscopy, and it is positive for moderately differentiated adenocarcinoma. When the pathologist works up the tumor, there are immunohistochemical staining done, which we'll go into later during this talk. It's for proteins MLH1, MSH2, MSH6, and PMS2. They're performed and they demonstrated retained nuclear staining for these proteins. We'll talk a little bit more later about what the significance of that is. So in June, prior to any consideration of removal of the mass, staging scans are done to make sure that this cancer is nowhere else in the body. He has a CT scan of the chest. It reveals emphysema. There is a small subpleural pulmonary nodule, sub-centimeter in the left lower lobe. There's some prominent mediastinal lymph nodes, but none of them are large enough to warrant a biopsy. The largest one being at the AP window, 1 centimeter in size, which is usually not something that can be biopsied. Then he undergoes CT scan of the abdomen and pelvis, and it does show wall thickening in the ascending colon. I don't think we're terribly surprised now that we know his diagnosis. He also has diverticulosis. He has no lymph nodes that are enlarged. He does have some very small hypodensities of the liver. They're too small to say what they are and not worth biopsying, and also maybe a cyst in the spleen. So with this, we feel that he's likely free of metastatic disease. He sees a surgical oncologist and he undergoes a laparoscopic ileocolectomy. So the pathology is taken from that right hemicolectomy. They've removed the terminal ileum, the appendix, and the ascending colon. It does demonstrate the same pathology, moderately differentiated adenocarcinoma. It is extended into the pericolic adipose tissue, and we'll find with TNM staging, tumor size, nodal status, and metastasis, which is how we determine staging of these tumors, that he is a T3 as it has gone into the pericolic tissue. It's greater than 4 centimeters in size. There's no evidence that it's tried to make its way to the lymphatics in the vasculature. And there are 2 out of 21 lymph nodes that turn up positive. So for him, our pathologic staging is a T3, N1B, and no evidence of metastases. So let's talk a little bit about colon cancer just as an introduction. So colon cancer lags behind only breast, lung cancer, and prostate as the 4th most common in the US. All of these now have screening that we can do, including for lung cancer. However, as far as death and mortality, it lags only behind lung cancer. Unfortunately, almost a quarter of the time, colon cancer is already found to be metastatic. More often, it's either localized or regional, spread to lymph nodes, such as in case of our gentleman. We can see that since at least the 1970s, when colonoscopy started to gain more popularity and used by primary care, that the mortality rate and the rate of new cases with polyp removal had steeply declined. Unfortunately, we've been seeing a concerning trend that it does appear that in younger patients, there does seem to be an increase of colon cancers. They are not typically screened for colon cancer unless if there is a history of young individuals in their family. But as you can see from the graph on the right, it seems disproportionately to be increasing in younger individuals. Younger patients show typical trends. Most of these are left-sided cancers as far as the colon. They are usually symptomatic at diagnosis. Unfortunately, oftentimes, at first, when they see their primary care, it may be attributed to inflammatory bowel disease, IBS. Usually, malignancy in younger individuals isn't one of the earlier ideas on the differential diagnosis. They are more likely to be familial cases, but the majority are still sporadic or de novo cancers. We're not really sure what's responsible to this trend. It may be a change in lifestyle habits, increased obesity, alcohol consumption, processed foods. So to go into how we in oncology look at these tumors, we think about our staging. It's a little different tumor to tumor. For colon cancer, we do use the TNM system, and this then organizes for us if the patient is stage 1 to 4, 4 being metastatic disease. So for our patient, he was a T3 as the tumor had gone into the pericolic tissues, N1B for 2 lymph nodes, making him a stage 3B. And again, we did not find any evidence of metastatic disease, so he is not a stage 4. But this is fairly high, more advanced tumor. So we would be concerned that he would be high risk for the colon cancer coming back even after surgical removal. So when we tackle colon cancer, it's a team of a surgeon and a medical oncologist. Just to note, for rectal cancer, we also use the assistance of a radiation oncologist in most cases. So for stage 1, there's no evidence for adjuvant therapy. Adjuvant therapy is therapy given after surgical removal to decrease recurrence. And we use chemotherapy for this purpose. Stage 2, there's a little bit of controversy, and I'll go into what that is. And then for stage 3, we generally use 3 to 6 months of adjuvant therapy. And that is because for stage 3, about half of the time it's a coin flip that it will return. But we know that we can reduce that chance with chemotherapy after the removal. For stage 2, they have about an 80% chance that it won't come back. And for individuals, we know from studies that they would gain about less than 5% benefit if they undergo chemotherapy. However, there are some individuals that are more likely to benefit from adjuvant therapy in stage 2. These are the T4 tumors, meaning that the tumor was found touching the viscera or the peritoneum. If less than 12 lymph nodes were sampled, in that case, we figure we really don't know how spread that it is. or if the cancer had perforated the bowel. Also, there's some consideration for those with lymphovascular invasion or very poorly differentiated tumors. This graph on the left just illustrates for the stage 3 folks, we usually use multi-agent chemotherapy rather than single agent. The gray and the red lines, you can see the gray line is stage 3 with combination chemotherapy, and the red line is single agent. And they tend to do better with a longer progression-free survival with the multi-agent chemo. And so that's what was approached with our patient. So after surgery, now it's July, he's had about a month to heal. And adjuvant therapy is discussed with the patient. Due to some recent trials, we used to put all of these patients receiving adjuvant therapy on about 6 months of multiple chemotherapies. Now we're finding that we can get away with about 3 months in some individuals, and he does qualify for this. So he's put on Zelox, which is a similar regimen to FOLFOX therapy, except one of the chemos is a pill, but essentially it's the same. So he is given 3 months on this chemotherapy regimen, and that lasts until October. Well, what happens after? Then we explore survivorship with patients, hoping that the cancer never comes back. They're met with their oncologists or surgical oncologists about every 3 to 6 months for several years. CT scans every 6 to 12 months, including a baseline at the end of adjuvant therapy. They get a colonoscopy a year out. They do have a lot of issues to deal with after therapy that is only becoming increasingly realized. There is this term chemo brain that's been used for years, but now it's really felt that the chemotherapy may have some cognitive effects on patients. There's increasing evidence for this, but we don't have a specific test, MRI, or any neurologic testing to really understand this yet. They have increased fatigue, sometimes helped by light exercise. And also they can suffer from anxiety, depression, sleep disturbances. So their cancer journey doesn't quite end with the end of treatment. And this is important also for primary care physicians to realize as well. So as I mentioned before, going forward, we want to get a clean baseline so we can start watching the patient going forward. So in November, that's what happens. So now we're going from May to November. So he's all finished with adjuvant therapy. He has had a CT scan of the chest, and this shows no lymph nodes. That left lower lobe nodule is essentially stable, and there's still his emphysema that's evident. He has a CT scan of the abdomen and pelvis. Now we're seeing something concerning. There is an enlarged subcapsular hypoenhancing lesion in the anterior left lobe of the liver, 1.2 centimeters, previously 3 millimeters. No one had been concerned before. These were sub-centimeter and not amenable to biopsy. There's also a new 5 millimeter subcapsular hypoenhancing lesion slightly inferiorly. So what's the concern? For colon cancer, it's very unlikely that it's going to metastasize to bone or brain. We usually see it metastasize to lymph nodes, liver, or lung. And in this case, the liver, which would not be overall surprising given the stage 3B colon cancer. So there's a high suspicion that this is metastatic disease at this point. So let's tackle metastatic disease. Here's a question, is it curable? So let's talk about metastectomy, essentially cutting out the metastases. So this was something that was actually started to be studied almost a quarter of a century ago now. In the late 1990s, almost 500 patients had their liver metastasis in colon cancer resected. And the thought process for the last century has been, if you have stage 4 cancer, it got there somehow. It's in your bloodstream. The cancer cells are there and can get there, and it's not curable. And we still tell patients this a lot for stage 4 cancers. However, for colon cancer with the liver metastasis removal, over a third of these patients were alive in 5 years later, with a median overall survival of almost 4 years. The only contraindication to that early study was metastasis outside the liver, but nowadays we also consider lung metastasis to be something that is, these patients are a candidate for metastectomy as well. Also, ablation has been looked at too for those that are not good surgical candidates, and thought if we aren't curing these patients, we are at least prolonging their life significantly if they have limited metastatic disease. It's also been looked in renal cell cancer. It's being studied also in breast and lung cancer, although that is not the train of thought yet at this time in those diseases. In general, with more widespread metastasis or to the lymph nodes, we use multi-agent chemotherapy, similar to our adjuvant therapies. We generally use FOLFOX, it's 5-fluorouracil, a vitamin called leucovorin, and also oxaliplatin, another chemotherapy. The other one we'll typically use is, again, 5-fluorouracil or 5-FU, leucovorin again, and irinotecan rather than oxaliplatin. And this is an older study, the Gerkor study, that looked at giving someone FOLFOX, and then eventually when the cancer learns how to progress through that chemo, switching it over to FOLFIRI. And they looked at giving FOLFOX followed by FOLFIRI or the reverse, and patients did just as well. So it really doesn't matter per se. In Europe, they often start with FOLFIRI. Over here, we often start with FOLFOX. Patients are more likely to keep their hair, but more likely to get neuropathy from the oxaliplatin. And this is one of the backbones of our treatment of metastatic colon cancer. As we're going to find out in this study, we've become a bit more sophisticated. So discussion has begun with him that he may have metastatic cancer. And as he had essentially thought to have progressed on adjuvant therapy with the equivalent of FOLFOX, FOLFIRI would be the next most likely option, at least as a backbone of his chemotherapy treatment. A PET scan is done to verify, is this liver lesion something we should actually be concerned about? Are we getting overly excited? Unfortunately, the lesion does show uptake on the PET scan, and he is referred to surgical oncology for a metastectomy. At the same time, planning ahead as this is likely metastasis, several molecular studies are ordered on the patient: KRAS, NRAS, and BRAF. As I mentioned, the chemotherapy is a backbone. We've become more sophisticated, and we may be able to find other options for treatment, either to add to the chemotherapy or for second line. As we had also mentioned before, immunohistochemistry had been done on mismatched repair proteins, which we will revisit. So the tests return. There's no mutation of KRAS or NRAS, which are fairly common mutations about a third of the time in colon cancer. He is positive for a BRAF mutation. Again, the mismatched repair proteins, the immunohistochemistry testing did retain strong nuclear staining for the previously mentioned proteins. Let's talk targeted therapies now that we have his molecular tests that have returned. This is a very complicated slide. It's really just to show all the complexities of the pathway that colon cancer forms and all the areas that have potential for intervention and are being studied. So these are the pathways by which the cancer cells learn how to survive and proliferate. This is a more simplified version. So you see the epithelial growth factor receptor, or EGFR, and downstream of that you have KRAS, BRAF, MEK, MAP kinase, and these promote the survival and proliferation of the cancer cells. So in addition to chemotherapy, what we can use to block that EGFR receptor are biologic agents, cetuximab or panitumumab. They are EGFR inhibitors. If KRAS is found mutated, that's not likely to work. So we do use a different inhibitor, a VEGF inhibitor known as bevacizumab, which we can add to chemotherapy. About 5 to 10% of the time in sporadic colon cancer, BRAF can be mutated. So this is our guy, this is our patient. In these patients, their colon cancer takes a different pathway for proliferation, or CpG island methylator phenotype, or CIMP. So it works a little bit differently. These are also patients in which the EGFR inhibitor generally does not work by itself. However, as it is upstream of it, there was a recent study, and this was from 2019, the Beacon trial, that looked at second-line use of the BRAF mutation. So these are patients that have progressed on the multi-agent chemotherapy, and they were given a BRAF inhibitor and also a MEK inhibitor, as you can see is downstream of the BRAF, plus an EGFR inhibitor to work on all of those areas in the pathway. And another group in the trial was given a BRAF inhibitor and just an EGFR inhibitor. And the other group was the control, chemotherapy plus EGFR inhibitor. Now, BRAF and MEK inhibitors have been used in other cancers. We use them in melanoma, we'll use them in lung cancer for those who have BRAF mutations, and they've been shown to work. And interestingly, though the doublet regimen of the BRAF inhibitor and EGFR inhibitor and the triplet regimen of the BRAF, MEK, and EGFR inhibitors were not compared head to head, they had similar efficacy of a prolonged survival. And overall survival was improved in both of these regimens, but the triplet regimen had more toxicity. Therefore, now it's approved for second line that a BRAF inhibitor and EGFR inhibitor can be used. So this is a potential option for our patient. There's some other targets that are now being considered. HER2 amplification, we do have HER2 targeted agents in other cancers, such as breast cancer. You may have heard of Herceptin or trastuzumab. It's one of the earlier biologics used. It is in about 3% of other cancers, including colon cancer. So now this is something being tested to give patients more options when they're in the metastatic setting. It is also higher in BRAF wild type individuals. And this patient was not tested for HER2, which is probably fine and appropriate at this point. In the future, there's consideration for KRAS inhibition. This has not been something in the past that we've ever had available, and KRAS is a very common mutation. It's actually been moving from the phase 1 to the phase 2 setting for a drug known as sotorasib in lung cancer, and this is fairly new. We don't have it available outside of a clinical trial at this point, but that might be an exciting future for multiple cancers as an opportunity for treatment. I'm going to pose this theory that's come up in the past few years, that right and left colon cancers are almost different diseases. And that is based upon the fact that the right side of the colon embryonically comes from the midgut, and the left side comes from the hindgut. And they may have a different basis pathologically. And we know that in right-sided cancers, which remember is our patient as well, are more likely to have BRAF mutations, which he does, be in older individuals and start off more likely as serrated polyps. Left-sided colon cancers, which as you'll recall, may be in younger individuals, can start more likely from tubular adenomas and be more likely to have KRAS mutations or EGFR or HER2 amplifications. So essentially different sides. This is our patient on the right. So this is an interesting study. This is from 2017. Essentially to support that theorem that the right side may have a worse prognosis than left-sided cancers. And what I think was interesting about this trial that looked at 6 other trials retrospectively, was they took out all the patients that had any RAS mutations or any BRAF mutations so as not to confound the study. And they just looked at who was on the left and who was on the right. And the control group had chemotherapy or chemotherapy plus a VEGF inhibitor, or the experimental group, chemotherapy plus an EGFR inhibitor. Turns out all the right-sided cancers did worse with overall survival, but particularly so with the EGFR inhibitors. So we do not use cetuximab or panitumumab generally with the right-sided cancers. So we now think that the right-sided cancers may have a worse prognosis. Unfortunately, our patient is in that boat and do not respond with EGFR inhibitors. A lot of patients will ask about immunotherapy. Finally, we get back to talking about those mismatch repair proteins. As you'll recall, he had retained nuclear staining. So he is not going to be a candidate for immune therapy at any time in the future. I'll explain why. So we find that there's a mismatch repair deficiency in patients with colon cancer about 5% of the time. There's a couple ways that this can be tested. First, we look at these proteins, MLH1, MSH2, MSH6, and PMS2, and we can test it with immunohistochemical staining on the tumor itself. And what these proteins do essentially is they correct insertion, deletion, or nucleotide base mistakes in DNA replication. And it creates these short tandem repeats or microsatellites that may have mistakes in them. And that's microsatellite instability high finding. And that can be tested by PCR. So whether the institution tests by immunohistochemistry or PCR, they generally correlate. Our institution tests with immunohistochemistry. One of the early studies that looked at immune therapy in these patients also looked at the average number of mutations in mismatch repair deficient tumors. And they had found on average over 1,700 mutations versus 73 in mismatch repair proficient. That's a lot more mistakes and mutations that are being made by those individuals more susceptible to cancer. What they also found was on histology of these patients that there were tumor infiltrating lymphocytes, suggestive that there was an immune response at the site of the tumor. So the Keynote 016 study in 2015 was one of the earlier studies looking at patients with mismatch repair deficiencies. And you'll see in the top graph, there were people with colon cancer, not large numbers to start, 10 patients with colon cancer, 7 patients with other cancers that were mismatch repair deficient. And you'll see from the waterfall plot below that with the blue and the black, these were your mismatch repair deficient cancers, and they had a response with immune therapy, specifically PD-L1 inhibition with pembrolizumab. The red, the mismatch repair proficient cancers, did not have a response. And now immune therapy is approved second line for colon cancer. The other interesting part about mismatch repair deficiency is it can be germline or passed down. So you can find mutations for MLH1, MSH2, MSH6, PMS2, or EpCAM, which ends up with the silencing of MSH2. There are people who have sporadic mutations. They are still candidates for immune therapy, but we find they have a hypermethylation of MLH1. They will be older individuals or BRAF mutation positive. So if our patient had loss of staining in those mismatch repair proteins with a BRAF mutation positive as he did, it would likely be that he had a sporadic mutation and did not have it passed down or pass it down to his own children. And we know this is Lynch syndrome or hereditary non-polyposis colon cancer. And so the testing that we follow through is we either do MSI testing or immunohistochemistry testing. And if we find there's a loss of mismatch repair proteins other than MLH1 or PMS2, they get referred to genetic counseling to see if they have Lynch syndrome in their family and a higher risk for colon and other cancers. If it's a loss of MLH1 or PMS2, they see if there's MLH1 promoter hypermethylation or a BRAF mutation, in which case it's probably not in the family. So just to go through inherited syndromes, non-polyposis colon cancer, we used to follow the Amsterdam 2 criteria before we became more sophisticated with mutational testing. And we found the pattern was, they go by the 3-2-1 rule. 3 or more relatives with colorectal or a related cancer, such as endometrial, small bowel, or upper GI tract with the hereditary non-polyposis colon cancer. These cancers span 2 generations, or someone had it under the age of 50. Now we have the best data guidelines for Lynch syndrome. And the criteria now includes the pathology of these tumors, including lymphocytic infiltration or microsatellite instability. Just to go through a few other hereditary disorders for colon cancer. Lynch syndrome is the most common, 3 to 5% of the time. It is autosomal dominant. It's more likely to be passed down. We can see colorectal, endometrial, small intestine cancer, and a variety of a few other cancers that these patients are counseled for, and for some of these screened. Familial adenomatous polyposis, these patients have multiple polyps at a very young age and often have a colectomy very early on. There's a few others listed here: MUTYH, juvenile, Peutz-Jeghers, Mutori, which also has skin tumors, and Turco syndrome with brain tumors as well. These are much more rare. Going back to our patient, December, he goes under a laparoscopic anterior hepatectomy, and not what we usually see. This patient has no evidence of viable malignancy. So that hepatic lesion turned out to be an immune reaction. It was a multinucleated giant cell reaction, and there was necrotic and coagulated amorphic material, but no finding of cancer at that location. So this is really not how we usually see this story with liver lesions end. So this is good. And we also know now he has a BRAF mutation should his cancer come back, but he gets to go back to surveillance. And we assume at this time he is cancer-free. Hopefully, the goal is for our patients never to get into this situation. Let's talk risk reduction, as I'm sure some of you listening to this talk today are in primary care. So things that can reduce our risk for colon cancer. It's thought that red meats may contribute. Now, all of these are through cohort studies of people followed for a very long time with very little control in the study. So what's been observed is maybe red meats may contribute, as heme iron can catalyze oxidative damage in the form of nitrosamines, or also grilled meats, polycyclic aromatic hydrocarbons can also cause oxidative stress and promote DNA damage and possibly colon cancer. Processed foods, high in fat sugar may contribute to inflammation, contributing to cancer, and also alcohol consumption. What we do know for many cancers, and there's a lot of growing evidence for this, is exercise is protective. The aspirin question. Patients do ask if aspirin is going to reduce their risk of colon cancer. There was a fairly large trial for Lynch syndrome, CAP2 trial, with over 900 patients with known Lynch syndrome. And they put them on aspirin for 4 years and found that there was a lower hazard ratio to developing colon cancer. But they had been on 600 milligrams of aspirin. I don't know about you. I've never met anyone on 600 milligrams of aspirin, never. There didn't seem to be a lot worse adverse risks or effects during the trial, but this is not, obviously not standard of care. We do know, going back retrospectively through randomized controlled trials for aspirin for cardiovascular risk reduction, that we can look at a lot of patients that way, and they did have reduced incidence of colon cancer. If more than 5 years, maybe a reduced risk in rectal cancer. And it didn't seem that there was any significance for doses higher than 75 milligrams, so you could still use a baby aspirin. So where did our guidelines actually fall on this? So the recommendation is aspirin may be helpful for your patients age 50 to 59 who already need it for cardiovascular risk reduction. And the reason this age level has been chosen is because it likely takes years to see the benefit of aspirin with colon cancer reduction. So putting your 80-year-old patient on it probably isn't going to help them a lot in the long run. Or I should say 75, as usually we don't do routine colonoscopies for age 80. But the point being, these younger patients may benefit put earlier on it if they already have another need for aspirin regardless. There's not a lot of evidence to determine the optimal dose, and each patient still has to be evaluated by yourselves if they have other risks for, say, GI hemorrhage, stroke, or other comorbidities where maybe we don't want aspirin on a daily basis. With that, I'm just sharing my references. Thank you so much. It's been a pleasure presenting, and I'll open things for questions.
There were a couple questions that came up on the Q&A. Feel free to post more. We have a little bit of time. So Dr. Jackson asks, are targeted therapies ever considered sooner than stage 4 disease?
That's a really great question. Actually, for adjuvant therapy, it hasn't been studied, as far as I'm aware, for some of the targeting such as BRAF or HER2, but it had been looked at for things like EGFR inhibitors like panitumumab and cetuximab. It was found not to be beneficial.
Then there's an interesting question here. Can the rise of poverty and lack of access to fresh, non-processed food be playing a role in cancer, in colon cancer happening in younger people? And does that imply newer types of screening for younger people?
Two good points in that. I don't know if we have a great study to show it, but I'm sure it plays a role. As we know, areas that have a poor socioeconomic population, they don't have access to grocery stores that run on thin profit margins for good food. And so there's higher processed foods from smaller stores, and that's definitely contributing probably to obesity, which then in turn can increase inflammation, but also other things, metabolic syndrome and other comorbidities. The second thing you mentioned was for earlier screening. The American Cancer Society is now saying for age 45 for younger screening. The U.S. Preventative Task Force Service is still saying age 50. As many of you in primary care know, it's really hard to get your patients to their first colonoscopy regardless. They're not lining up to get it. For younger than that, it's generally people who have someone in their family who had colon cancer in a young age or familial mutation. Then the guideline is to screen them 10 years younger than that.
Yeah,
hopefully that helps to answer.
Right. So you answered this question about the 45. How much does obesity and vitamin D play a role in colon cancer prevention?
For obesity, again, a lot of these are based on cohort studies that are not as well controlled, but it's suggestive that the increased inflammation may play a role in developing colon cancer. For vitamin D, I don't know if it's specifically been looked at in colon cancer. I know there's a lot of studies out there for vitamin D with other cancers. And I think for breast and others, there's a suggestion that low vitamin D may not be beneficial, but we don't know how high the vitamin D actually has to be. For colon cancer, I don't know if that's been specifically looked at. I think it's a great question.
Yeah. And then I think this one is more a comment than a question. It says, isn't 650 milligrams of aspirin 10 grains? So isn't that the traditional take 2 aspirin and call me in the morning? I think it might be. I think what you were saying, though, was people don't tend to be on that chronically.
Yeah, that CAP trial was for 4 years. Take 2 aspirin for 4 years and call me later.
And then, of course, we can't finish this without a COVID question. How has COVID impacted the screening for colon cancer? And how many more colon cancers do we expect from a decrease in screening that occurred over the past year?
In my own practice, I haven't been seeing what I've been fearing, but there were a lot of people not being screened. I'm worried about people presenting more symptomatically and more like the younger colon cancer patients who often do present symptomatically. It's not the goal. I'm just going to back up to one of my slides way back in the beginning. Bear with me. So this is the slide with the colon cancer screening from the 70s. So it wasn't just decrease in mortality, it's a decrease in the incidence of colon cancer itself with polyps. So we may not know for a few years, I suspect.
Yeah.
The true impact.
So it'll be interesting to see what happens to our cancer registry data if there's a shift towards higher stage of disease over the course of the next year. So you're missing them more early, but they're going to show up with later stage disease. I guess we'll be monitoring for that in many different cancers. Did people not get caught early enough, and are they presenting with later disease? I mean, I think that's an interesting hypothesis.
Right, and
not
just later disease, but also disease that didn't have to be there at all.
All right. Well, with that, I think we're going to call it a grand rounds. Thank you. That was interesting. Great update. And see everybody next week. Have a good week.
Thank you.